Hello everyone, my name is Kate. I'm from Guangzhou Medical University. Today we are going to talk about osteosarcoma, in short, OSA. Here we begin with a clinical case. A 12-year-old boy presents to the emergency department with difficulty weight-bearing on his right leg. Reports a 1-month history of right thigh pain above his right knee. Physical examination. Palpation of the medial and lateral aspect of his right knee, at least tenderness, and there is no evidence of laxity or joint effusion. Here is the imaging examination. In the picture A, we can see a radiolucent lesion involving diaphysis of the distal femur with an associated irregular periosteal reaction. In the picture B, biopsy of the distal femur lesion, demonstrating a tumor with pleomorphic nuclei intimately associated with eosinophilic osteoid matrix. Diagnostic of osteosarcoma. So the diagnosis is conventional osteosarcomas, a high-grade aggressive neoplasm, and is the most common primary malignant bone tumor in both pediatrics and adult population. Here we know something about osteosarcoma. Salient clinical features. Most common primary malignant tumor of bone. Painful mass. Bimodal age distribution. Primary and secondary categories. Usually distal femur or proximal tibia. Associated with leaf laminae and retinoblastoma. Prior radiation, Paget's disease. Radiographic findings, poorly demarcated blastic or lytic mass, soft tissue extension. Pathologic findings, permeated pattern of woven bone created by malignant cell. 3 primary variants, including fibroblastic, chondroblastic, and osteoblastic. Evaluation of the post-treatment resection for percentage of tumor necrosis is the key. Outcome and treatment. With multi-drug chemotherapy, prognosis have improved with 70% long-term survival. In the end, the patient is treated with preoperative chemotherapy and subsequently undergoes a definitive resection that reveals a necrotic thin-white tumor within the medullary space. The tumor is extensively sampled and shows near complete necrosis histologically. Here we can see the picture C, resection specimen of the distal femur, demonstrating a large 10 red to 10 white tumor within the medullary cavity with extension through the cortex into the soft tissue. Here we learn about pathogenesis about OSA. Approximately 70% of osteosarcomas has acquired genetic abnormalities, such as complex structural and numerical chromosomal aberrations. Molecular studies have shown that these tumors usually have mutations in well-known tumor suppressors and oncogenes. RB is a critical negative regulator of the cell cycle. Patients with germline mutations in RB have a 1,000-fold increased risk of osteosarcoma, and somatic RB mutations are present in up to 70% of sporadic osteosarcomas. TP53 is a gene whose product functions as the guardian of genomic integrity by promoting DNA repair and apoptosis of irreversibly damaged cells. Patients with leaf laminae syndrome who have germline TP53 gene mutations have a greatly elevated incidence of osteosarcoma, and abnormalities that interfere with P53 functions are common in sporadic tumors. CDKN2A is inactivated in many osteosarcomas. This gene encodes 2 tumor suppressors, P16, a negative regulator of cyclin-dependent kinases, and P14, which augments P53 function, MDM2 and CDK4, which are cell cycle regulators that inhibit P53 and RB function, respectively, are overexpressed in many low-grade osteosarcomas. So how is OSA treated? Currently, high-grade conventional OSA is treated with neoadjuvant chemotherapy, followed by complete surgical resection, which has drastically improved 5-year survival in patients with this disease. Unfortunately, the overall prognosis remained poor in patients with metastatic or unresectable disease. Prior to the use of neoadjuvant chemotherapy, patients were treated with surgery alone, and approximately 80% of patients succumbed to the disease. However, with current modality treatment, the survival rate is around 16 to 70%. According to the WHO, good prognostic factors including localized disease involving distal sites, greater than 90% tumor necrosis after neoadjuvant chemotherapy, and complete resection with clear margins. Poor prognostic factors including proximal location of disease, large tumor size, metastasis present at diagnosis, and poor response to neoadjuvant chemotherapy. Therefore, the pathologist examination of a resection specimen for the treatment response and margin status is critical for the patient's clinical outcome. Thank you for your listening.